right, hello everyone, good morning. So the title of my talk is Making an Attending. It's a 4-year jigsaw puzzle. So I think Taylor handled the education for the morning. I'm going to provide more of the anecdotal talk for the day. So let me just get my buttons. All right, good. So this photo is basically how I view residency. The individual hands all represent individual attendings. And basically throughout residency, they all provide us with individual puzzle pieces. And these puzzle pieces represent, specific experiences, observations. They represent moments of praise, of criticism, debriefing, pimping, whatnot, so on, so forth, etc. And basically, when you go throughout residency, you collect these puzzle pieces, and they go inside your brain, and they float around. Gradually, they find each other. And ideally, at some point in your 4th year, they come together and they create an attending. So the purpose of this talk today is basically to share with you guys a few of the puzzle pieces that I've collected over the past 4 years. I'm going to share specifically 10 of these pieces, okay? Now, just a few disclaimers before I start. Every single attending that I've worked with has given me a valuable puzzle piece in my personal attending puzzle. That being said, this is a 30-minute lecture. And I've already used like 3 minutes. So bear with me. All right, so jumping right in. The first piece I'm going to share with you all is to fight for your residents and fight for your juniors. Just to set the scene a bit, my very first CCT shift as a senior was a terrifying thing. As it should be, it's a terrifying place. It's full of terrifying patients. And one unique aspect or facet of that terror is the question of who is going to be your attending, right? Now, I'm one of those residents who doesn't ever check who I'm going to be working with. I just don't do it. I never have. I don't think I will at this point. So for me, I went into my first CCT shift as a senior with that same mindset. I'm just going to see what happens. And I started thinking about it. The closer it came, who is it going to be? And I realized there's really only one attending that I'm afraid of. And don't get me wrong, like I'm afraid of, I have fear for many attendants, okay? Like a healthy fear, like a godly fear. But there's really only one at that point in my career that I was genuinely afraid of, and that was Dr. Bond. I don't really know why, honestly. I don't have a great reason for this. I've never had a bad experience with Dr. Bond. She's always been great to me. But I don't know what it was. I was just afraid, and I was afraid she was going to think I was dumb or something, and I don't know. You want to impress, you want to feel comfortable, and that's kind of the mindset I went in, and I was afraid of Dr. Bond. Sure enough, my first CCT shift was with Dr. Bond. And not very long into that CCT shift, I had my very first level 1 trauma code as the senior, and that was a head trauma and it required intubation, right? And as we all know, the seniors get the trauma intubations in the CCT, and I'm a baby senior at this point, but I am the senior. This is like a June CCT shift, okay? So I'm brand spanking new, and I'm soiling my pants. And to make things worse, the trauma surgeon who came down was, I'm not going to name anybody, but he was on the feistier end of our trauma surgeons. And he really had essentially zero confidence in my ability to intubate this patient. And he was rather vocal about that. He made it very clear very early on that he wanted the anesthesia attending to step in and to take this tube. But it was Dr. Bond that fought for me. She was right there by my side, vouching for me, encouraging me, telling me, you got this, get your stuff together, just get prepared, you're going to do this. And she created enough of a mental aura of confidence around me to allow me to focus and actually get that tube. And it was a real mic drop moment for me. It was one of the best moments in my residency. It gave me enough confidence to sort of get my seniorhood rolling, and I appreciate that. So yeah, this piece is fight for your residents and seniors, fight for your juniors. This next puzzle piece is share your resources with your residents and your juniors, okay? And the attendings that have really given me this piece have been D'Souza and Dr. Tang. D'Souza, where do I begin? Dr. D'Souza is a challenging person to work with, okay? And I mean that in a good way. I don't mean that in an offensive way. But when you have a Dr. D'Souza shift, you know that you're gonna, be questioned. You're gonna have your management styles scrutinized, and you're gonna have your comfort zone sort of pushed a bit. And I think that's genuinely a valuable aspect of working with Dr. D'Souza. It's something I look back and I really appreciate those moments. But another aspect of that is, throughout my 4 years, he's always tried to make a point to send me resources after those shifts and to send me articles and literature to try to, expand my knowledge of various presentations and cases and branch points and decision making and so on. And I've always appreciated that. Dr. Tang is another one. I remember being a junior with E. Tang as the senior in CCT. For some reason, we were matched up quite often. And, we've had a lot of crazy cases. For me, a lot of foundational cases that really taught me a lot. And I remember going home and oftentimes finding an email sitting in my inbox from E. Tang already, just like sharing links to blog posts that he's personally reading up on and improving himself and just sharing them with me. And I really appreciate that. I found a lot of resources that I don't think I would have found if it were not for those emails. And that's something I try to do with my juniors today. And I think it's something that I would definitely want to do with my residents going forward. All right, the next piece is pimp your residents. All right, now I think there's definitely an art to pimping, right? Not everybody's great at it. But I think when it's done correctly, it can be very valuable. One of the few aspects of my internal medicine rotation that I actually appreciated was the attendings really prioritize pimping in when they teach. It's everywhere. They really look forward to it. It's just part of the culture to sort of pimp their residents and their med students. And I think part of why our EM program is so strong is because we have a lot of that internal medicine blood floating around in our program, right? Through these EMI and people that we have. Specifically for me, it's been Dr. Beta and Dr. Hassel. Beta, I worked with, and I had him for CCU, I had him for SICU. I spent a lot of time with this man. And he has sent me a lot of articles during that time. And I think, those in and of themselves would have made me better, just leaving it at that. But I think what really pushed me to be a better doctor is knowing without a shadow of a doubt, I'm going to get pimped the next day, right? Without a doubt, he's going to find me. He's going to question me on whatever it was that he sent me the night before. And it just made me approach it differently. It made me read these articles, not to just read them, but to actually be ready to recall that info. And I'm definitely a little bit better because of that. So I appreciate that. Dr. Hassel, can I say he is an absolute master. I think he's completely mastered the art of on the fly pimping specifically. I mean, like, no warning, no heads up, just out of the blue pimping, right? He's got this down to a complete science. I actually had a CCT shift with him yesterday, and I was thinking in the back of my head, like, the whole time he was doing it, I was like, I'm going to talk about this tomorrow. I can't tell you, but this is perfect, right? Like, he finds a way to extract a learning point out of every single case, no matter how mundane, no matter how simple, and then pimp you on it in a way that makes you learn. And that's one of the most valuable parts of working with him. So I can't talk about these EMIM guys without obviously giving credit to Papa Schechter, who, he set the ultimate example in this category. Dr. Schechter, I think, is a great all-around attending to work with. But there's two things that specifically I look forward to working with Dr. Schechter for, and the first is NFTs. I've had enough slow early morning CCT shifts with Dr. Schechter to kind of pique his interest just enough to gradually pull him into this NFT world, and it's been very fun. The other thing is rounds, right? Dr. Schechter, I always look forward to rounds with him because, at some point he's going to inevitably pimp the entire group. And he's gonna bring us all back down and make us realize that, wow, rounds have value for us to actually learn and become better physicians as opposed to just taking attendance and signing out. And I always appreciate that from working with Dr. Schechter. This next puzzle piece is argue with your residents a little bit. All right, and I have to give an honorable mention to Schechter and D'Souza. I think they both do a great job of doing this. But for me personally, it's been Dr. Valesky who's really hammered this one home for me. He's really willing to get inside the ring and spar with you pretty much anytime, anywhere. And I always appreciated that. I actually, I had the gall one time to ask Dr. Valesky why he believed in TPA. I think he was a stroke fellow for a stroke code that I called when I was a senior in CCT one time. And I'll never forget it. He looked me in the eyes and told me he was going to give me 30 minutes to an hour to gather my thoughts. And then he was going to come back down in the middle of my CCT shift, and we were going to have a formal debate about TPA. I'm not joking. I swear to God, he came back down within that time frame, and we had a legitimate 20-minute debate proctored by Jane Kim on TPA, and it was hilarious, and it was at times aggressive. But I look back at it with a genuine appreciation. That among other debates I've had with him. Just a few quick facts, though. While we're on the topic, there were 12 trials studying TPA. Right, just quickly. Only there were 10 of these 12 trials showed no benefit whatsoever. Right. 4 of those trials actually were stopped early because they showed so much harm. 2 of these trials were positive. Right. The NINS had a 13% benefit. The ECAS-3 had a 7% benefit. These were never replicated. And there's this thing called the fragility index, and it basically stands for the amount of patient outcomes that would need to change in order to change a positive study into a negative study, right? And if you look at the fragility index for the first positive study, it's 3, right? So 3 patient outcomes would need to change in order to turn that positive study into a negative study. Then if you look at the index for ECAS-3, the other positive study, it's 1. Okay, so if you changed 1 patient outcome, that would be negative. So just moving on, and this was actually a slide that I got from Robbie Allen's senior lecture, so I'm just passing these along. Okay, the next puzzle piece is always keep your cool. Dr. Willis, when I was an intern, hang on, I think it's freezing on me. Are we good? When I was an intern, Dr. Willis picked up a patient primarily. And that patient was one of the most disrespectful patients I've ever seen, still to this day. The guy was in an absolute mess, right? He was intoxicated, he was making scenes left and right. He was cursing out the nurses, he was spewing racial slurs to all the patients around him. It was just absolutely disgusting to watch. But what was absolutely beautiful to watch was Dr. Willis go over there and interview and examine that patient. Just the racial slurs, the curses, the derogatory comments just bouncing off from like he's made of stone. It was incredible to see. It was just like a shockingly stark contrast of the utmost disrespect with the utmost undeserved respect by Dr. Willis. And I doubt he even remembers that encounter, but for me, it was a core memory. For me, anytime I have a disrespectful or difficult patient, I think back on that example of Dr. Willis going into complete ice mode with this sociopath, and I appreciate that. So the next piece I'm gonna share with you guys is go the extra mile for your residents. And the attendings that have given me this piece have been Dr. Weiner, Dr. Little, and Dr. Morales. So there is a shift out there that exists. It's rare, it's difficult to get. I've sadly never been fortunate enough to catch this shift, but it is possible. And what it is it's an overnight shift, okay? And it's when you're overnight and the attendings in the ED are Dr. Little, Dr. Morales, and Dr. Weiner. And the reason why, the reason why this is called a wellness trifecta shift is because this is the only shift you can actually look forward to. Dr. Wiener's snacks, Dr. Little's social rounds, and ideally you get a Kelly breakfast to top it all off. You know, these guys have really made it a point to find a unique way to make us residents feel appreciated and seen. And I think I speak for everybody when I say we appreciate that. You know, like I genuinely look forward to that inevitable epic chat from Dr. Wiener, you know, announcing the arrangement of beautiful snacks that he has lined up for us. I also, of course, look forward to the inevitable Dr. Little visit, you know, where he finds me no matter where I am in the ED, just to crack some jokes and, you know, get me to take a break and just laugh a bit. And then, of course, you know, residency at Kings County wouldn't be complete with a healthy amount of overnight rum punch at a Kelly breakfast. I don't know what my thing is going to be, honestly, but I know that, you know, after my experience with these guys, I definitely want to have a thing for my residents moving forward. Go the extra mile for your med students. So the attendees that have given me this one are Dr. Gore and Dr. Smith. You know, I was fortunate enough as a med student, I was a first year med student, I was able to be a part of Dr. Gore's med student program in the summer. And, you know, it was just a great opportunity to sort of work with former seniors and to get, you know, advising and counsel from current attendings. I actually remember getting like very personalized advice from Dr. Smith when we were on like a personalized little attending panel. And it blows my mind that I was actually able to sit alongside Dr. Smith this past summer on that same exact panel and give personalized advice to med students who are in the same program that I was in 7 years ago. And it just felt great, you know. It's something that I definitely want to continue doing. And it's something that honestly, I don't know that I would be standing up here today, you know, speaking to you guys about to graduate in a month. If it weren't for, you know, these attendings among others who took the time out of their busy schedules to invest in me. This is the next puzzle piece I'm gonna share with you guys this morning. And this is know your weaknesses. All right, so I'm gonna actually play a little game for this one. Basically the way it's gonna work is I'm gonna say a word and I want you all to blurt out the first attending that comes to mind, okay? And for people on Zoom, you can actually type in the first attending that comes to mind, okay? So here we go, say a word, first attending, shout it out, ready? Discharge. Amazing, okay. That was, I think, 100%. So, I mean, we all know that nobody can discharge a patient faster than Dr. Sinner, right? It just can't be done. The man is a data-filled discharge machine, right? He was built for this, right? This is what he does. But there's something about Dr. Sinner that not everybody knows, all right? And I'm gonna share it all with you, okay? I hope he doesn't mind. But what not everybody knows about Dr. Sinner is in the last hour of his shifts, Dr. Sinner actually switches modes. Dr. Sinner actually switches modes from high volume discharge mode to low volume workup mode, right? Suddenly he starts sending blood work, he starts ordering CT scans, it's insane. And the reason why he does this is because he knows his weaknesses, right? He knows that he has a bias toward quick discharges. And, you know, we all obviously know that as well. But he knows that in the last hour of every shift, that bias actually increases, right? So he deliberately, in order to counteract that, does these workups that otherwise he would never even consider. And I appreciate that, I respect that. And for me, the takeaway there is to really find your weaknesses and then do whatever you need to counteract and to control for those weaknesses. All right, so second to last piece here. An ER doc with trust issues is a good ER doc. Okay, and the attending who's given me this puzzle piece is Dr. Silverberg. Okay, when I was an intern, I had a CCT shift with Dr. Silverberg. I got there early, as one should, as a junior, and I was, you know, going through all the rooms, going through the airway cards, making sure everything was restocked and whatnot. And I finished that. I was headed back to the desk to get ready for rounds. When I saw Dr. Silverberg in the corner of my eye, he was in room 2, and he was going through one of the airway carts. I was like, all right, I'll go over there, and started to assure him that I had gone through the airway carts already, and that I'd actually done it in all the rooms, and he didn't need to worry about this. I had this one. I did this already. And Dr. Silverberg looked at me with the same smile that he actually has in this photo. And he said, I like you, Julian, but I don't trust you. He told me it wasn't, not to take it personal, that he didn't trust anybody. And immediately a core memory was formed, right? Immediately I started thinking like, wow, damn, Dr. Silverberg, the legend himself, right? He doesn't trust anybody. Maybe I shouldn't trust anybody either, right? So I don't know if that was his goal there. I don't know if he was joking, but either way, I think it was an overall good thing. Growing up in residency, especially in ER residency, constantly reminding yourself to not trust anybody, right? It forces you to sort of dot your I's and cross your T's and try to do that for everybody around you, right? It's not a bad trait to have as an ER doctor. So the irony comes, I had a shift with Dr. Silverberg a couple of days ago, and I asked him if he saw my chest pain patient because I wanted to discharge her. And this time he looked at me again with that same smile, and he said, I haven't, but I trust you, Julian. You know what that did to me? I felt good. It felt damn good for like a couple of minutes. And then I started thinking about it even more, right? I was like, hang on, let me think about this. Do I trust Dr. Silverberg to trust me on this? Do I trust him to not dot my I's and cross my T's and just go with the flow? So I actually ended up getting back up and going to see the patient again, reassessing, re-examining a bit. I went through the chart, I rechecked the EKG. I basically reconvinced myself that, she's all right, she's fine, she can go, he can trust me on this one. But the takeaway for me was that I had really become an ER doc with trust issues. And I think that it's made me a better ER doctor. And I don't know if this is true, but I think that was his plan the whole time. And I appreciate that. All right, this is the last puzzle piece I'm gonna share with you guys. This is the final one, and that is Run the List. I think we all know who gave me this one. This is none other than Dr. Hochstein. Okay, I have nothing to expound on here, other than just, if you take nothing else from this lecture, please remember, run the list. All right. I just want to thank every single attending who's ever attended me. It's been a hell of a journey, and I've genuinely appreciated every moment. That's it.